This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Thank you very much. The question set was calling criteria for children. I don't know actually if I know how to answer that question, so I'm sort of posing it back to you. I'm sort of asking you, what are you expecting to hear? Because I think a lot of this subject is loaded up with cognitive biases and errors and expectations, so I'm not sure what you're going to hear today. I'm not sure if it'll necessarily answer all your questions, but hopefully it'll be interesting. And I was just listening to Angus and envying his certainty. To have a patient group with narrow physiological variables and little physiological reserve who have oodles of cardiac arrests and there's tons of data, that would be pretty cool. Sadly, in paediatrics, for lots of reasons, things are not quite so clear-cut. So just a few questions to start off with. Stick your hand up briefly if you have a rapid response system or team in your own institution. Don't be shy. Yeah, pretty much everybody. Does anybody here who has a team or a system not have any calling criteria? Nobody. Of the people here, and we're a select and sophisticated audience, how many people here actually, as part of their job, develop calling criteria? A couple of hands going up. I share your pain, particularly if you do paediatric ones. Is your system the best? Stick your hand up if your system's the best. We're all human. But more interestingly, what do your frontline staff think about the tool that they're using? And I don't need answers, but just have a think about that, because often there's a big disconnect with tools that we sit in ivory towers and design and what people actually feel about them at the bedside, and sometimes that translates into what they do with them at the bedside. And those of you who do root cause analysis and coronial inquiries will see sometimes the system failures. And again, just thinking about adverse events, which do you think apply? Does anybody think that sometimes your calling criteria misses critically ill patients? Does anybody think that sometimes your calling criteria overpicks your patients? And do you sometimes see that calling criteria nails your patient, but your staff, for whatever reason, fail to escalate? So actually, perhaps not just in paediatrics, perhaps more generally, we do still have problems with our calling criteria. So just thinking about rapid response teams, what's their purpose? Ideally, you're going to provide a high-level clinical assessment, high-level decision-making ability, confidence and the skills to deliver critical intervention, to gatekeep critical care access, because we all have finite resources, and ideally sometimes specific local or regional knowledge, who to phone in the middle of the night when you need something done, how to organise a retrieval of a sick patient from the back end of nowhere. There are lots of things that we really are looking for in a team. However, who do we have to staff that service? I think the point's been well made earlier today that depending on where you work actually significantly affects how you might be able to respond to a sick patient, to a sick child. In a tertiary facility, you're likely to have reasonably senior people from both the intensive care unit, the emergency department, the paediatrics, other base teams turning up whenever somebody recognises a deteriorating or critically ill child in the ward. If you have the same patient and you're in a regional facility, potentially your response is with an adult rapid response team, or perhaps you'll have a local workaround where instead of the adult team, the paediatric SMO or registrar is called in their stead. And I'm not aware that there's particularly, I know about Queensland, I'm not so sure about other parts of Australia, but I know we do not have a universal approach within Queensland for how we manage this type of thing in the regions. However, if you're remote and rural, and Queensland has substantial numbers of children cared for in remote and rural facilities, your response is whoever happens to be available and whoever you can phone in, phoning a friend from home. There may or may not be some remote support either by telemedicine or by phone, and there are systems available if people know to phone. We are dependent on lots of staff coming and locuming or very junior staff working rural relieving terms who perhaps don't really know who to phone or how to access help. And then while there may be some skilled help available, they're not available immediately. And it's not terribly uncommon for us to take 12, 24 hours to get to a bedside within Queensland, geography and weather depending. So when to call? And again, we've sort of circled around this a little bit today. Clearly, if you are suspicious that somebody has a critical illness, that would be quite legit to make a phone call to somebody. If you recognise clinical deterioration which you think is going to require a significant escalation of care or posing a significant risk of serious harm to your patient, also seems very reasonable. But this needs to be timely. And to be timely, again, there are factors like your service capability, which will help determine timeliness, geography and meteorology. I know the point's been made that there shouldn't be any geographical variations in physical observations, but if you have to fly somebody 8 hours when there's a thunderstorm, it changes what you perceive as timely. And again, depending on what disease process you're facing, very significantly changes when the right time is to move. And I'm absolutely spewing and gutted. I thought I was being all clever. I should have gone first. Interestingly, astrophysicists and astronomers talk about the Goldilocks zone round about stars. It's the area of the right distance from a star where liquid water can exist, and it's of interest because that's where you look for planets that might potentially bear life as we know it. When you're thinking about calling criteria, however, Goldilocks still applies. You don't want to go too early, you definitely don't want to go too late. Just right seems about perfect. But imagine you're in an institution who's just had a really horrid, public, messy death of a cute child, and you threw all the papers and the local politicians jumping up and down, and protesters are going past your institution. If you're risk averse, then perhaps you need a system of calling criteria which are just set just that little bit more sensitive. If, however, you work in a place not terribly far from where I live, where you don't really want all your expensive and trained intensive care and ED staff to be roaming around the hospital, day and night, seeing patients that don't need to come because you can't afford to run that service, perhaps a different set of calling criteria is more appropriate for you. And then about pathology. Imagine you have two conditions, condition A, condition B. Condition A is a condition that is often rapidly progressive with subtle clinical signs, or the ability to weight the clinical signs is rather subtle. Potentially causes severe adverse outcomes commonly, for example, an MRSA pneumonia. Whereas you might also have condition B, which is a slowly progressive disease with very barn door clinical obvious signs. Rarely kills your patients in an ugly fashion like bronchiolitis. So potentially, depending on the disease you are treating, it might be good to be able to vary your calling criteria. It would seem sensible if you can do it. And let's just stick with condition A, pneumonia. Again, potentially, when you have a patient come in and you think they have pneumonia, you don't actually know what kind of pneumonia you've got. If they've got, it's a viral pneumonia or an atypical pneumonia, probably there's not going to be any big drama. But if they have something rather more unpleasant, potentially the calling criteria you've set may just be a little bit too late. So all of these are factors. And then I talked already about the distance. Picking patients at the right time depends on how long it takes you then to get them to definitive care. The further away, the earlier you better be be at picking them. And that leads to uncertainty. So within paediatrics and adults, there are a number of different ways of identifying patients, calling criteria, if you like. Physiological observations is how pretty much all of us do it in Australia. There are many examples. I don't really want to talk about any particular system or any particular subset of system, but it's a common way of doing it. Illness descriptors I touched on in my lecture before lunch. I've got another slide on this to talk about. Disease specificity, clinical pathways, and I'll flag just the CEC sepsis pathway at the moment because I think it's timely. It's a timely hot topic, and this is a problem that is probably responsible for most of the severe adverse events that might be preventable, certainly in children. Unrecognised or late recognised sepsis is perhaps the biggest killer we've got. Parents and carers as a calling criteria, and the button, which actually is my favourite, but it's the least good system of all. Here's a button. As my very kind introduction flagged up, I have a shiny new hospital. It's a thing of beauty, and I feel very privileged to go there. And that's good because I go there pretty much every day. And we have these shiny buttons absolutely everywhere. Even the dingiest, darkest service tunnel has got buttons. They're in all the toilets, they're in all the wards. Interestingly, when the hospital was built, these shiny buttons, which activate our MET response, were put at just the right level for small children to reach. And little arms could snake out quite happily from cots and hit the shiny button. And pretty much the very day we opened, we got thrashed immediately and in a sustained manner by a very, very, very unpleasantly hearty dose of MET calls. And it was a design fault. Okay, it was a design fault. And you're saying, well, you know, this isn't a calling criteria. Why are you talking about this? This is an activation when, you know, you're recognising critical illness and you want a team to arrive. But in our hospital, for a little while, it was. The solution was obvious. Cover it up with something. But it was really interesting. It took a little bit of time to cover up all the buttons where little fingers couldn't get at them. But we actually fixed it an awful lot faster than that. So pretty much the same day that it became apparent we were getting leathered by inappropriate calls, really with the first shift changeover, as the phone was passed across, the instruction was passed across. You know, all the calls are false calls, don't rush, essentially. And I watched it happen a bit. A call would go off, people would lever themselves out of the seat, and they'd slowly start shambling in the direction of the lift. Not too fast, because you were waiting for the stand-down call. And the stand-down call would come in within 30 to 60 seconds. And you say, it's just another one. And that's a crazy system, because you have no idea when that call goes off, if it's a true one or not. But because of the extraordinary number of ridiculous calls we were getting, immediately staff constructed a workaround. For 99.9% of the time, that was entirely appropriate. In fact, you probably don't even need to put your cup down. Trouble is, because you don't know, it's a completely inappropriate response. And I'll touch back on this in a minute. But humans have a real rare talent for working around things that they don't like. I'm not against buttons. I quite like buttons. I have a panel of buttons on my desk. So I'm not bagging buttons, but you just need to use them properly. This is a bit of a busy slide. I'm not in the slightest bit apologetic for it. If you start off with this green line in the middle, all the graphs are essentially the same. The green line is the median 50%er for respiratory rates for hospitalised children in Queensland who didn't have a severe adverse event and lived to tell the tale. And this is by year of life. I have the same graphs for babies between 0 and 1 year of age by month. And to make this graph, there's almost 21,000 respiratory obs on it. So you've got a median, you've got 75th, 90th, 95th centiles, and the same going down the way. So this represents all the respiratory rates for children for almost 2,000 children hospitalised in Queensland at all stages in their illness, from their very sickest to the last set of obs before they go home. And this is actually really important stuff, because if you were going to design a system that had to deal with hospitalised patients, these would be the kind of numbers that you would need to design your system. Sadly, we designed our system and only worked out the numbers after we'd done that. Does anybody else in the same situation? How dumb's that? Yeah? But that's where we're up to. We've got another 21,000 or 22,000 heart rates, and we've probably got 10,000 systolic blood pressures. So actually, we do have a database for children's hospitalised observations who don't get into trouble. These charts are, if you like, the different ages of charts for Queensland, for New South Wales, for ACT, for Victoria. And they almost look the same. One of the striking things about it is, actually, for a lot of the different age groups of children, you can be between the 5th and the 95th centiles in hospital and not trigger anything. I find that quite remarkable. Sometimes I feel like I should pull the coloured bands in just a little bit and maybe snug some of these patients up. But you can see, because there are subtle differences between the different tools, you would expect that the different tools are going to perform slightly differently. Two of the tools are cumulative scoring systems, where you actually have to add up heart rates, respiratory rates, blood pressures, things. And the other two charts are essentially single trigger scoring system. Your parameter hits a coloured box, you respond. So we have different tools. You would expect, looking at them, that they're likely to perform in different ways. Looking at mine, because that's the only data I've got to talk about, looking at almost 1,900 children in hospital who didn't die, the highest score they got at any point in their entire hospital stay was 3 or less for 83% of the patient group. And that meant they never got a review by anybody of any grade of seniority. Is that the right setting? Hard to know. This graph here was provided by one of my ED colleagues. It's smaller numbers, but these are unscreened ED arrivals children, and the highest scores they had at any point in their ED stay. And I think this is about 87%. Looks very similar to the 83% we got for hospitalised patients. So again, we seemed to have a system that was consistent, that didn't grossly overpick children. Now, I also have ROC curves for patients by adding in some children who did have miserable adverse events and go to intensive care and sometimes die. And I know that comparing the tools that were currently available in Australia in 2011, for the patients I had in the hospitals I looked at the time I looked, my tool slightly outperformed the others. Does that mean it outperforms? Does it mean it's the right tool for every child in every hospital in Queensland? It doesn't. Does it mean it's the right tool for children in other states? It doesn't, because the whole preamble up till now, where actually your scoring depends on what your pathology is, where you are, what resources you have available, means that if you like, it almost makes sense for individual institutions to select out the tool that works best for them. So I know the patients I've got, I know the institutions I've looked at, I have some data to back up what I do, but it doesn't automatically translate across that it's the right tool for anywhere else. And within my institution, there are some patients who won't get picked, just like the question earlier on, do you have patients that your tool doesn't pick? We have them too. Illness patterns are interesting. So this was criteria for one of the studies I presented before lunch, an illness pattern sort of calling trigger. I think this is really interesting. We've gone physiology, and we believe strongly that it's right. But we fool ourselves because even though we have patients who might have observations in the white zones, it doesn't mean they're safe. It's perfectly possible to die with your observations in the white zones, and we need to be careful about that. So while we don't do this, I'm actually interested for certain types of conditions in thinking a bit more about this. So for example, in the intensive care unit I work in at the moment, there has been a grassroots appeal to have a laminated sheet that they can write down what numbers we are happy with for our critically ill patients every day. What respiratory group, what do you want? What saturation do you want? What do you want the blood pressure to be? And that's fine, but it worries me because it's not how my brain works. I would be almost more interested in saying, for example, illness patterns. This patient today, I am very worried, might develop low cardiac output state. The things that I want you to look for as a pattern might include rising lactates, falling urine output, say loss of sinus rhythm. You can add whatever you like in, but rather than saying, I'm happy to accept saturations of 94%, you could be dying with saturations of 94%, turning up the ventilator, turning up the oxygen, but the number's good. For certain things, it might make more sense to try and spot worrying patterns, particularly with subtle things like low cardiac output state. What about lung protective ventilation? You can say, today I want this patient to have lung protective ventilator strategy because they've got really sick lungs. So I want to know if the pH is falling, and I'd like you to keep the pH. I'd accept a pH between 7.25 and 7.4. I want to know if the CO2 is up, and I want to know if it's down. But 60 to 80 would be a reasonable ballpark place to look. Saturations. And I want you to come to me before you adjust the ventilator because I'm worried about this pattern. So while in the studies, we're sort of moving away from this type of thing for calling criteria, there might be certain diseases that benefit from a global pattern approach. And then there are disease-specific things. So this is the CEC's Sepsis Pathways. I'm really happy that this is happening. Sepsis is the biggest killer of, or biggest potentially avoidable killer of children in my state. And I'm really glad somebody is looking at this because this is really hard stuff. So all power to the CEC for taking this on. There are pros in trying to think of a system like this. So it's a big problem. It's a subtle problem, and it's often picked late. And potentially your window of opportunity to intervene is very narrow. So having a big focus might help you to miss less patients. There are downsides. If you actually read through some of these criteria, lots of hospitalised patients meet criteria. I took the liberty of looking at my bronchiolitic patients under a year, of which I have 100 and something, 180 or something like that. And of hospital admissions with bronchiolitis who don't get into trouble, probably 10% of them trigger this system. If you look at the bronchiolitics who were in the high flow trial that we're running at the moment, 40 or 50% of bronchs will trigger this system. So again, with this type of thing, there is often a worry that there's a poor signal-to-noise ratio, and when it's ping, ping, ping all the time, and you just say, oh, it's just another bronch, for goodness sake, what's this tool all about? The potential exists for staff to either ignore or to come up with workarounds like, sitting down and drinking your tea during MEC calls. So I think this is good. I'm going to watch this with a lot of interest. I should have done something about this myself ages ago. But again, just for the guys who are working on it, I was delighted to see that you've managed to slip in a cumulative scoring system into this tool. That's excellent work. There are a number of system problems that we have. We have a stretched system, and potentially where you set your calling criteria, stretch the system further. We talked about balance in a previous lecture. Just moving things to a different department doesn't help the system necessarily. Staff have a really poor understanding of how escalation systems work. Do you find that, people who have systems, bedside nurses, bedside junior doctors. I find it's really, people understand this very poorly, and they have inappropriate expectations of calling criteria. They expect that the tool is going to pick their patient. They don't expect that the tool will go off and they look and say, oh, this patient was completely well, why is the tool going off? And they certainly don't expect the tool to miss patients, but all these things are possible. If there's poor understanding and inappropriate expectations, then the potential exists for variable buy-in from frontline staff, and again, that leads to workarounds and poor compliance. Cognitive bias is a major, major, major problem, and this is where I spend most of my time thinking and working at the moment. This is about diagnostic errors. We know in perceptive specialties like radiology and pathology that your diagnostic error is about perhaps 0.5 to 2%. In busy, unsorted patients in EDs day and night, your diagnostic error is more like 15%. There are a large number of potential cognitive biases that lead you to a wrong diagnosis and then reinforce, confirmation bias and diagnostic momentum, reinforce that error continuing, being passed on down the chain. Cognitive bias is a major problem, but potentially how you design your triggering tools can act to minimize cognitive bias. They can be de-biasing tools. So just to conclude, some of my thoughts on this. Calling criteria absolutely are a compromise. And I think the best tools are likely to be those that institutions select based on what fits their particular geography and staffing capability and disease profiles. And it almost requires people working in a particular location to look at their patient population and saying, well, this is what seems to work best for me. There's a real need to engage frontline staff. If you have a tool that just keeps calling you back every hour, it's like saying, are you sure that's the right diagnosis? Are you really sure? You've treated them as best you can. Are they getting better? Do you need to phone somebody else? Do you need to move them somewhere else? It's an opportunity to just keep rethinking. When people keep getting phoned back every hour because, the chart's going off, usually they go, oh, it's bloody rubbish, this. I've seen them 4 times already tonight, and, they haven't died yet, so this is rubbish. But actually, we're making a mistake with how we sell this to people. It's a misconception. I did a coronial inquiry quite recently where expert witnesses said because a senior physician attended this patient from the get-go, there was no need to keep phoning MET criteria in this remote rural hospital all night, and the child died in the morning. Maybe there was nobody in the hospital who could have come running to provide better care at the time. But to keep getting ping, ping, ping radar going off, you're flying into the ground, that should have provoked consulting with somebody outside the institution. So cognitive debiasing, I think, is really important. Human factors design. The better we design the tools, the better they will work to debias people. And within reason, standardisation is still very important. So we have a single tool for Queensland. Is it the right tool for all patients? Absolutely not. Is it the best compromise that we've got, allowing for standardisation? It probably is as best we can get it on paper. Now, I think technology offers us orders of magnitude improvement, and that point has been made by other people. But beware, some of the things I have seen on the horizon at the moment gives us the opportunity to significantly worsen lots of the human factors things around about detecting patients. So to say we have to go to computer because it's a computer is stupid. We have to go to computers when they offer increased, enhanced ability to pick sick patients, but we shouldn't jump until it can offer something better than what we're doing already.